Spinal muscular atrophy. It is an autosomal recessive condition in which the degenerative process affects the anterior horn cells of the spinal cord and causes neonatal hypotonia, floppy baby. It is caused by a genetic defect in the SMN1 survival motor neuron gene on chromosome 5q, which encodes SMN protein, which is apparently selectively necessary for survival of motor neurons. Most important keywords include anterior horn cells of the spinal cord, SMN1 survivor motor neuron gene on chromosome 5q, which is apparently selectively necessary for survival of motor neurons. It is one of the most common neuromuscular disorders, with an incidence of about 1/10,000 births. Spinal muscular atrophy manifests in various degrees of severity, which all have in common progressive muscle wasting and mobility impairment. Most important keys: it is one of the most common neuromuscular disorders. It manifests in various degrees of severity. Types of spinal muscular atrophy. Type 1, called Wernicke-Hoffmann disease. It occurs from 0 to 6 months. Type 2, it is called intermediate spinal muscular atrophy. It occurs usually between 6 and 12 months. Type 3, Gugelberg-Welander disease. It occurs from second year of life in childhood, adolescence, or adulthood. We will talk now about the Wernicke-Hoffmann disease. It is the severest form. It has the early onset and rapidly fatal course. Mostly important points: severest form, early onset, rapidly fatal course. Clinically, it starts in utero or within the first few months of life. Severe hypotonia, so sitting and weight bearing never achieved. Severe limb and axial weakness, poor head control, bell-shaped chest, intercostal weakness, and diaphragmatic breathing. Respiratory problems, which often lead to pneumonia and early death. Suckling difficulties, weak cry. Histologically, it is characterized by large groups of atrophic fibers, what is called fiber type grouping, target and targetoid fibers, hypertrophic type 1 fibers, atrophy of both fiber types, Some samples from early cases may show minimal change, pre-pathological. Most important keywords include fiber type grouping, targetoid fibers. A motor unit is made up of a motor neuron and the all muscle cells it supplies. This is motor neuron. These are branches of motor neurons. These are the muscle fibers showing myofibrils. When there is a cut here, this group of muscle fibers are affected in one so-called fiber type grouping. The muscle biopsy is characterized by a phasic appearance resulting from abundant uniform small rounded atrophic fibers with focal admixture of often clustered normal sized or hypertrophied myofibers. This is a group of atrophic fibers. These are hypertrophic myofibers. The most important key here is biphasic appearance. These diagrams are stained with AT base at 9.4. Most of the larger fibers are type 1 and many of the atrophic fibers appear as type 2 fibers. We see here, these are dark atrophic fibers at pH 9.4. The type 2 fibers are affected. Here, type 1 fiber are atrophic, which are pale. Here also, this high power, type 2 fibers, which are dark, are small and atrophic. These are fibers which are pale, are hypertrophic. Also here, normal and hypertrophic fibers. This is NADHTR staining, the target fibers. The target fibers reveal three distinct zones: a clear central zone without oxidative enzyme stain, an intermediate zone with increased oxidative enzyme activity, and a relatively normal staining peripheral zone. The keywords here, three distinct zones in the target fibers. This is targetoid fiber. Targetoid fibers reveal two distinct zones. It means no intermediate active zone. The key words, two distinct zone, no intermediate active zone. Here we see NAD HTR of a single muscle target fiber. We hear central clear zone without oxidative activity. This is intermediate zone with increased oxidative activity. This is a peripheral zone which has a relatively normal staining. This is targetoid fiber. It has clear central zone, peripheral zone of relatively normal staining, no intermediate active zone. The targetoid fiber is a non-specific finding. It is also seen in central core disease, metabolic conditions, in healthy individuals following exercise, and in association with other gene defects. For example, ACTA1, MYH7. The most important keyword is the targetoid fiber is a non-specific finding. This is H&E of anterior horn. Histology reveals a loss of motor neurons from the spinal cord, most obviously in cervical and lumbar regions, and from hypoglossal and other motor nuclei in the medulla and pons. Some of the remaining motor neurons may appear swollen. The most important key word here are loss of motor neurons. Motor neurons, when die, they are replaced by glial tissue, the process called gliosis. The remaining neurons may appear swollen. This is a swollen neuron. Molecular basis of disease. Survivor motor neuron SMN1 is homozygously deleted in nearly all of type 1 and type 2, and about 80% of type 3 spinal muscular atrophy. 2 to 5% of type 1 spinal muscular atrophy is caused by compound heterozygosity for an SMN1 deletion and point mutation. The reliability of molecular analysis has revisionalized diagnosis of spinal muscular atrophy, and the role of muscle biopsy has diminished. Important keywords include survival motor neuron SMN1, the reliability of molecular analysis has revisionalized diagnosis of SMA, and the role of muscle biopsy has diminished. As regard of treatment, there is no known cure for spinal muscular atrophy. Palliative care includes respiratory care, nutritional care, mobility, and orthopedic care. The most important keywords include no known cure but palliative care. As regard of prognosis, spinal muscular atrophy 1, it usually results in death at 4 to 6 weeks from respiratory failure. SMA2, typically it is associated with a survival of over 4 years. SMA3, it is usually associated with survival beyond late adolescence. Thank you.